think this has been a great discussion, and as you can see, we reviewed a lot of the different data, and I've learned a lot, and every time we discuss these things, I think we all learn a lot, and that I think tells us that not everything about CML is well known. There's still things controversial. There's still a lot of things that we need to continue discussing, understanding better, listening to each other, and I think that that's the value of programs like these. So just to conclude, I would like to ask each one of you to give me very briefly just your final thoughts, a final message that you want to give to the physicians out there that are treating patients with CML. I'll start with you, Harry.
Well, you have three choices now. The second generation drugs have shown a lower risk of progression with a manageable toxicity profile. I think the important point is whichever one you choose, you optimize adherence and reduce toxicities of any of them by close monitoring of those patients. And it's very important to do not only hematologic monitoring, but PCR monitoring at 3 months and at baseline 3 months and every 3 months afterwards. Try to avoid rapid changes between drugs because of intolerances that could be managed, or a single PCR value that's a little bit out of range or out of whack to what it was. Make sure you recheck it before you make any big decisions.
Thank you. Kevin?
Yeah, I think the biggest problem we're seeing now, we have all these different medications available to us, this wealth of really effective treatments, and the temptation is to switch very rapidly from one treatment to the other for minor toxicities or for any minor variations in the PCR. And we are getting referred patients who've seen all the different TKIs, and they're being referred for clinical trials or what have you. And you look back and see whether the patient was genuinely intolerant to one of those medications or not, and it can be quite difficult to go back to a medication that the patient had been on previously because the patient thinks, no, I tried that and it didn't work. So I would appeal to the community physicians and to all the physicians treating CML to really try to manage the toxicities as best as possible before making a switch to another agent.
Javier?
So I think we are in exciting times to really treat patients with CML. I'm very fortunate that I treat those patients. And I think when I see them and when I really come back to the community oncologists, what I really try to educate them, and sometimes I try to educate my community oncologists through my patients. So are sometimes the one who really may more interested that this early monitoring and continuous monitoring take place. So we are try to guarantee that they will have the same outcomes that the one that we see in the clinical trials. Of course, quite excited to really see the new data on discontinuation, and really looking forward to really see how these new approaches can really be fit in our practice and in our patients.
David, wrap it up.
I'd like to make 2 points. One is that we've made tremendous strides in controlling CML. We're not all the way there. I think that one point is I think combination therapy is something that we really need to look at, particularly boosting immune response. The other word of caution I would put in, as Kevin mentioned, that generic imatinib is on the way. I would put a word out to the insurance companies who may feel motivated to require generic imatinib as first-line therapy for all patients and only go to second-generation TKIs when they fail. As I said before, I have a zero-tolerance approach in terms of avoiding progression. I think that strategy exposes patients to risks. We don't know that we can salvage patients if they fail first-line TKI to go to the second at that time, and I would be very cautious about that.
Well, thank you, gentlemen, and on behalf of our panel, I would like to thank all of you for joining us today. I hope you enjoyed this program.